Good morning, everyone. Just want to turn the mic off. Sorry, I was having some technical issues. Good morning, everyone. Can everyone hear me okay? All right, perfect. I'm going to get started so that we stay on time. So this is our part 2 of Grand Rounds, which is a crash course in critical care topics for non-critical care providers. And we're going to start off with cardiovascular considerations in coronavirus. So with a lot of what we know about coronavirus already, a lot of it is based on anecdotal reports. We don't have much hard data on what happens to the heart and with cardiovascular disease. What we do know from the 2 big studies that have been published, these case series on coronavirus in China, we were able to see that patients, as you can see on the table on the chart on the left, patients with troponin elevations have a much higher mortality, about 50% compared to about less than 5% mortality for those without. And if you combine troponin elevations with known cardiovascular disease, that mortality rates goes to about 70% in 50 days. So obviously this is a bad indication, bad prognostic value for patients. It's unclear exactly why that happens. It could be, we certainly have cases of pericarditis and myocarditis associated with coronavirus, but is it just a marker of kind of disease severity and also kind of patient comorbidities, or is there something else going on specific to coronavirus? So since we can't talk specifically about coronavirus and cardiomyopathy, I'm just going to talk about cardiomyopathy and sepsis and how we treat it in general. So myocardial dysfunction, as indicated by a decreased ejection fraction, happens to about 14% of patients with sepsis. We see a higher rate if we just look at troponin elevations. Up to half of these patients with sepsis will have troponin elevations. This is likely due to inflammatory cytokines and myocardial dysfunction. But what does that really mean? And, you know, just knowing that this is a bad prognostic indication, how should we actually treat these patients? So, you know, as with a lot of things in critical care, we go back to Manny Rivers' early goal-directed therapy, where you know, this was a study done in 2001, which used a bundled treatment plan for patients in sepsis. And in that, you will recall that inotropes were used to achieve a central venous oxygen saturation target of 70%. And that led to about a 15% use in dobutamine in the treatment arm. And that was kind of used as kind of gold standard therapy for a while. Since then, a lot of studies have come out questioning specific goals of this study, including the central venous goal of 70% and the use of inotropes to achieve that. So a series of very large, well-randomized studies came out between 2014 and 2015 that looked at that specific question. And in that situation, the new treatment was to not be as invasive and use less inotropes. So in the control arm, they used oligo-directed therapy and used dobutamine, and in the the non-early goal-directed arm, what they call the usual care arm, these studies ended up with much less dobutamine use, between 0.9 and 3.8%. And in that situation, despite using less dobutamine, there was no difference in mortality. So it seems that the take-home point should be that there's no indication to routinely check central venous oxygen saturation and to not routinely use inotropes for just a central venous end marker in sepsis. There are other studies to kind of point to the fact that inotropes don't seem to help much in sepsis. I just highlighted a few. Gadinoni study looked at central venous saturation outside of early goal-directed therapy, and that didn't decrease mortality. Another study looked at sublingual microcirculation, basically an end marker of adequate cardiac output and perfusion, and that did not seem to increase dobutamine. And I think most interestingly, another study looked at 90-day mortality in a propensity-matched cohort of patients treated with inotropes and those without, and inotropes seem to actually confer a higher mortality of 42% versus 24%. So it seems like that question is solved, that we should we treat sepsis-related cardiomyopathy? And the answer usually seems to be no. But of course, there's a caveat, and to highlight that, I'll just bring up a patient we saw in the CTICU a few months ago. This is a 50-year-old active woman with history only of rheumatoid arthritis, presented with severe ARDS. This was before coronavirus, and had a influenza pneumonia and septic shock. She received 10 liters of crystalloid overnight, and was going up on escalating doses of norepi and basal. Initially for VV ECMO, until we saw the echo, which showed severe, previously undiagnosed myocardial dysfunction as evidenced by these echoes. So obviously, this is something that we don't want to miss, and especially giving them vasopressors, giving the patients vasopressors and crystalloid fluids is the wrong thing to do in this situation. So we have to look for warning signs of decompensated heart failure, and just to remind you of what those are. Escalating vasopressor without a response, signs of end organ dysfunction such as acute kidney injury or lack of response to diuretics, cold extremities, hepatic congestions, although it should be noted that transaminitis can happen with coronavirus, but that's usually mild in the kind of hundreds range. Persistent acidosis despite adequate resuscitation, and an ultrasound, either point of care or a formal echo, can be useful in this situation. So inotropes, I'm not going to talk too much on the doses, but usually in sepsis we use dobutamine, as well as other options being epinephrine and milrinone. I'll have these slides up afterwards on the team page so that people can kind of review it afterwards. Next topic, really quick, is going to be arrhythmias and sepsis. The most common arrhythmia being atrial fibrillation. This occurs in about 10 to 40% of patients in sepsis. And there's a lot of variation in management. The etiology can either be from an already arrhythmogenic atria due to structural heart disease, various other problems, which are kind of exacerbated by sepsis, and all the factors in kind of blue on this diagram here show all the things that happen, toxins, situations, cytokine surge in COVID can happen to arrhythmogenic and normal atria that can lead to these problems. So what do we do for treatment? Very quickly, we of course distinguish between stable and unstable, and unstable will go to the ACLS pathway and usually apply electricity to this situation. If it's a stable atrial arrhythmia, we first try to remove the offending agents, usually that being the inotropes, if possible, and then optimize the patient's atria for a chance of not having atrial fibrillation. So that includes replacing electrolytes to a K of 4 to 4.5 mag/2, as well as untreated infections, so making sure there's adequate treatment and source control of infections, adequate volume status so the patient is not hyper-distending the atria and causing atrial stretch that will lead to atrial fibrillation, and also making sure pain, agitation, things that can kind of increase catecholamines are taken care of. Without hypotension, usually in these patients, we usually start with a beta blocker with metoprolol. If there's accompanying hypotension, we think about cardioversion or use of amiodarone. So there are different medications that we can use for atrial fibrillation. Beta blocker and calcium channel blockers seem to be kind of equivalent in various studies that we've used. Our institution, we just tend to use beta blockers a little bit more often, although diltiazem infusion is perfectly reasonable. In addition, if there's hemodynamic compromise, we will resort to using amiodarone, which seems to have less of an effect on SVR, although amiodarone in kind of large enough doses will still be a negative inotrope. Usually we give 150 milligram bolus and then followed by a drip at 1 milligram per minute for 6 hours, and then cut it in half for the remainder of the 24 hours. Digoxin is also a consideration, but we have to be careful with, especially with renal impairment, as far as reaching toxic levels. Last thing I'll touch base on is the use of ECMO. We are, of course, an ECMO center, so we do have patients on VV ECMO for coronavirus. Usually that's accomplished using a single cannula in the right internal jugular vein that has 2 lumens, so that one will suck out blood and oxygenate it and return it back into the right atrium. This is called a crescent or an Avalon catheter. ECMO has been shown in 2009. There's been 2 big studies on ECMO. In 2009, Caesar showed that there's decreased mortality when patients are transferred to an ECMO center, but it wasn't randomized to the treatment itself. It was a transfer to the ECMO center. And more recently, in 2018, Eolia did not show an improvement in mortality, but was criticized for a high crossover. So the non-ECMO arm ended up with 50% of patients on ECMO during the study. So even though it didn't show improved mortality, I think there's still a strong belief in ECMO being able to save patients. The big question then becomes, what do we do with patients what do we do with the ventilator when patients are on ECMO? Do we extubate them? Do we possibly prone them? Or do we use a different kind of resting settings for the ventilator? The way I think about it, extubation is probably difficult because that'll lead to significant de-recruitment of the alveoli. Proning can potentially be helpful since it distributes the pulmonary edema and kind of the stress on the alveoli. And this is a picture of a patient being prone on ECMO. And I think what we most often do is kind of resting setting where we keep a high level of PEEP to keep the alveoli open, but decrease the amount of pressure to prevent distension of the alveoli. I'm not going to go through the process since we're up on time, but ECMO at UCH involves consultation with the cardiac surgeon as well as the CTICU attending to make sure that this is an appropriate use of resources for our patients. And we have a list of contraindications that we try to follow for these patients. Currently, we have 6 patients that are on an ECMO. 3 have been successfully decannulated, 3 remain on ECMO, and unfortunately, none of them have been discharged from the ICU. So I'll take questions at the end, and I'll have Dr. Kraus move on to the next topic.
Hello, everyone. I hope you can hear me. I'm going to talk about RV dysfunction in COVID patients, and you just heard from Maung that there's a high rate of cardiac involvement in COVID patients, and I'm going to focus on RV dysfunction as there's a lot of changes in these patients, which puts a lot of stress, especially on the right ventricle. So when it comes to the etiologies of RV dysfunction in these patients, obviously everything which affects the heart globally, such as viral myocarditis, demand ischemia, from hypoxia or hypertension, will obviously not only affect the left, but also the right side of the heart. This is particularly stressful for the right side of the heart when it comes down to its oxygen demand, because it also has to push against an increased right ventricular afterload. And the reason for that is that, first of all, you have a patient who is already hypoxic, hypercapnic, and acidotic, and therefore has an increased PVR. But also these patients have extremely high PEEP settings, and ARDS by itself can cause some irreversible changes, which further increase PVR as well. Later on during the admission, a lot of these patients, secondary to their hypercoagulable state, develop a lot of PEs. And if the left ventricle also starts failing, the stress and the RV afterload is even further higher. Some of these patients even develop viral pericarditis and some tamponade physiology, but that's relatively rare. So you should have a high suspicion for RV dysfunction, specifically if you have signs of diminished forward flow, and Maung already elaborated on some of these things, especially if you have a patient with increased pressure requirements, despite adequate or aggressive volume resuscitation, who's now clamping down with a low pulse pressure and some signs of and organ ischemia, who at the same time also show signs of venous congestion, such as acute transaminitis and a rising CVP, which can both be indicators of the limited compliance of the right ventricle. Those are patients you want to have a low threshold of either ordering a TTE or actually performing bedside ultrasound echo by yourself. And I think most to probably all of you guys actually have the skills to identify severe RV dysfunction just by eyeballing some of the echo images. For example, in apical 4-chamber view, you will easily appreciate how well the free wall can actually contract towards a longitudinal direction towards the apex, or in this particular example, which you should see on your screen, how poorly that actually works on this patient. If you quantify this via M mode, and the cardiologist on the official read will do that for you, It's a so-called TAPSE, and in this particular patient, the excursion of the tricuspid annulus towards the apex is less than a centimeter, which correlates with severe RV dysfunction. Another important thing to look out for is the sheer size of the right ventricle. If it gets more and more dilated as it has an impaired forward flow, we'll start noticing that it starts becoming the same size or even larger than the left ventricle, and even starts sharing the apex with the left ventricle, or even occupies all of it. When at the same time, as you can see on the images below, the septum starts deviating towards the left ventricle, bulging over, that means that you already have existing right-sided pressure or volume overload. And if this happens in an acute setting, not in a chronic but acute setting, this is basically a sign of impending failure. So you got to treat it relatively quickly at this point. And I think all of you guys are experts when it comes down to decreasing your pulmonary vascular resistance by non-pharmaceutical measures, such as avoiding hypoxia, hypercapnia, acidosis. But the things I want to elaborate a bit more on are the inotropes of choice, vasopressors of choice, pulmonary vasodilators, and diuretics. Starting with inotropes, in general, I think that you can always make a point of epinephrine in patients with COVID, especially if they have a component of cardiogenic shock and at the same time a component of vasodilatory shock, as epinephrine is a quite potent systemic vasoconstrictor. One of the issues with epinephrine, though, is that it's also a very potent pulmonary vasoconstrictor. And that is why in RV dysfunction, particularly, you might want to choose a different option, such as dubidamine or Merinone, which are both having vasodilatory effects as well. And this is particularly important, as you can see on the right graph here, that the right ventricle is extremely sensitive when it comes to increased pulmonary artery pressures. The stroke volume decreases pretty quickly, and it doesn't have the reserve and the strength of the left ventricle. Keep in mind that Merinone sticks around for a long time. It has a long half-life, and it gets even longer if you have a patient in AKI. For that matter, dubidamine might be a better option as it is on and off relatively quickly. Just keep in mind that dubidamine is a quite arrhythmogenic agent itself. Obviously, if you use these so-called inodilators, you might run into the issue that your systemic blood pressure falls down again. But the systemic blood pressure is very important, especially in patients with RV dysfunction, because it provides the coronary perfusion pressure, the driving the forward pressure to it. And so you want to make sure you maintain this blood pressure. Norepinephrine, which is usually the first line agent for sepsis, has its advantages. And you're probably in a lot of patients who are needing a lot of pressors, you might not get rid of all norepinephrine, but keep in mind that norepinephrine itself increases your pulmonary vascular resistance as well. An agent which is a bit better suited is vasopressin. It has its own side effect profile, but it has no to possibly minimal effects on the pulmonary vascular resistance, which makes it a great agent for RV dysfunction, as it doesn't contribute to any increase in pulmonary artery pressure, but provides coronary perfusion pressure. At the same time, in contradiction to norepinephrine, it also doesn't have any beta agonism, which may be a topic. A lot of these patients might present hypertensive because they're in RV dysfunction, but not so much because they're volume down. And a lot of these patients, especially if you think about the images I've shown you of the dilated right ventricle, actually do need to be decompressed, do need to get volume off. And the reason for that is that they're probably about to fall off the Frank-Starling curve. They try to move more towards the left in a more optimal position where the stroke volume is significantly improved again. So for that purpose, you oftentimes have to diurese these patients despite the fact that they might be on inotropes and pressors. And the agents of choice are usually loop diuretics, oftentimes in combination with thiazides such as Diaril, as they together have a quite synergistic effect and are able to offload volume relatively quickly. If your patient remains oli or anuric and you're unable to handle the volume overload with diuretics, you pretty quickly have to go to dialysis. And since all these patients are hemodynamically unstable, you should, if available, go to continuous renal replacement therapy via a dialysis line. This is probably going to be limited in the next few days to weeks as we are running out of dialysis machines. But we're currently doing 12-hour runs of dialysis. Basically, instead of CRT, we're kind of calling it a prolonged intermittent therapy, so that one machine can actually be used for 2 patients in the course of 24 hours. Real quickly, inhaled pulmonary vasodilators oftentimes have a role in these patients as kind of a last resort drug. While it doesn't show any benefits of mortality, what it does do is it's a particular vasodilator for the pulmonary vasculature. While it doesn't affect systemic, the systemic blood pressure, and what it leads to is that the right ventricular stroke volume improves on these inhaled pulmonary vasodilators, and it also has a nice side effect that it also improves oxygenation. This is secondary to the fact that most nitric oxide gets absorbed from vessels which supply alveoli which are well ventilated, and therefore what you basically see based on that mechanism is that you have a lower shunt fraction in these patients. We have 2 agents available, inhaled nitric oxide and inhaled epoprostenol. We tend to use inhaled epoprostenol as it is 10 times cheaper than nitric oxide. They're both pretty safe agents, but that is basically our first choice. When you have to use these drugs, they are oftentimes titrated by the respiratory therapist, which helps significantly, as you don't have to titrate these drugs by yourself. Real fast, I'm probably already over the time, but since this is a topic which has been coming up lately, if you do have pulmonary hypertension from an acute PE, there has been a lot of debate if empiric TPA might be a good option for patients who have refractory hypoxia and hypertension. None of these patients ever makes it to a CT-PE scan as they're all too unstable, and we don't want to contaminate anyone. But the long story short, as well as already utilized in Italy, New York, and Boston, that there's no evidence for it. And unless a patient is coding, or basically unless you have maxed out on all mechanical ventilatory support as well as on all hemodynamic support, you probably shouldn't utilize it. If the patient is coding, there's probably the benefit risk evaluation is probably on the side of the benefits, but otherwise than that, you should be careful utilizing it. And that's it.
I think
Okay,
you're next.
guys, I am up next. I'm just gonna try and share my screen real quick. Okay, I am going to talk to you guys about shock in the ICU, and in particular reference, obviously, the patients with SARS-CoV-2. And you'll see, I'm sure a lot of people understand the difference in nomenclature. The SARS-CoV-19 and SARS-CoV-2 are the same virus. SARS obviously refers to the illness from the COVID-19 virus. CoV-1 is the SARS virus that we saw an outbreak in Asia and especially in Canada that caused such devastation, that had about a 9% mortality for all those infected. So I'm going to describe the approach to shock that in general we've applied in critically ill patients, and then review some of the case series of why we think some of these patients are specific and that their shock is slightly different than what we normally see. So, unfortunately, some of us have experienced this, that we are trying to manage these patients specifically to the disease of the virus. And we're referring to some of the case series that have come out, but unfortunately, they're ongoing case series, and the data is constantly evolving and incomplete. And I'll share with you an email that I got this morning about some of the demographics at the University of Colorado after I introduced these 3 case series. So initially, out of Seattle, a case series of 24 patients was published in the New England Journal and had an exceptionally high mortality. When you delve into kind of the demographics of those patients, though, the concerns for the high mortality ended up that there was a significant number of those patients that presented to the intensive care unit with do not resuscitate orders. So it's very tough to kind of assess the mortality of the virus and patients in shock when they have a do not resuscitate order. In China, what was one of the major concerns was the lack of testing. And they were actually, they've got a lot of criticism from the international media, but what they did was an incredible job of kind of validating the early PCR by looking at, they had a very high rate of patients who came into the hospital who immediately got CAT scans. And from those CAT scans, they tested basically the sickest of those patients who had hypoxemia and shock, and they correlated those with the CAT scans. In Lombardy, Italy, a lot of the database, then the most recent published in JAMA, actually had a lot of the data collected over the phone, not extracted from databases. And I'll give you, a real quick update on the demographics that we've learned this morning. That at the University of Colorado, we've admitted 287 patients with COVID. Of those, 92 have been ventilated. 31 have been extubated, so almost a third, and 149 patients have been discharged. 13 patients have been readmitted, and 17 patients have died from the COVID virus. So 17 out of 287 admissions. And 11 of those that have passed away have been over the age of 75 years old. Again, it doesn't say if those are healthy 75-year-olds or not healthy 75-year-olds. So the best demographic is kind of an ongoing database from the NHS that encompasses England, Wales, and Northern Ireland. But it is also incomplete because it's ongoing. But the difference is this is directly extracted from the medical record. And some of these patients have been requiring up to 2 to 3 weeks of mechanical ventilation. There's a low overall ICU admission, and mechanical ventilation has carried as high as a 70% mortality, but also as low as a 30% mortality and a 26%. And it'll be very interesting when we start finally having more data from our institution. So these patients are very complicated, and in addition to how complicated they are, we also have to deal with this strange world of how do we evaluate these patients? How do we keep our providers safe? How do we keep our attendings safe? How do we keep our nurses safe? How do we not over-test these patients? But the SARS-CoV-2 have special considerations. Shock is a major cause of death in a lot of these case series. And the potential causes for shock that we have seen are vasodilatory, cardiogenic, as Mong and Martin had talked about, but then also because of the length of stay of these patients and sometimes where they're coming from, iatrogenic infections or nosocomial infections seem to be a big problem. And it's very tricky right now of how we determine if a patient has a ventilator-associated pneumonia, on top bacterial pneumonia, and then potentially central line associated bloodstream infections. The big question is the virus attacking the heart, or does the stress of critical illness actually affect the heart? And Martin and Mong have already discussed this, but some of the challenges we've had are often because the hospital has done a great job of shutting down visitors, and this started, over in Asia and in Italy, and we followed their course. Often you don't have great medical history from these patients themselves, and what I think we'll see is a lot of people have discussed some of the disparity in patients from different minority groups and from the poor. And my thought on this is that you're seeing patients obviously coming in clusters, and patients who are probably living in more tight quarters. And this is one of the concerns of why New York City and different parts of Italy, that you have a lot of cohabitation of multiple generations of people. There were early reports of fulminant myocarditis, all out of major centers in Wuhan, Italy, and Seattle. And it's very clear from these that ICU admissions have higher rates of medical comorbidities. We have seen patients of younger age who don't have access to healthcare. And when you probe their families over the phone, it does sound like that potentially diabetes seems to be a major medical comorbidity. We have had many patients who have presented in DKA, and some of these patients obviously will develop or have developed coronary artery disease. The vasodilatory shock seems very specific, and some of the incredible work that's been done and some of the agents that we're using as far as blocking the cytokine storm in these patients have really brought this out to the forefront. It looks like this, you could describe it as basically an inflammatory shock, and some of our pathway treatment and monitoring involves measuring LDH, IL-6 levels, D-dimers, platelet counts, CRPs, and ferritins. And what we've seen as this course has gone on is some of these patients get dramatically better with sirolimus. And again, this is an ongoing clinical trial, but in my experience, early blocking of IL-6, it's a monoclonal antibody, seems to dramatically decrease patients' inflammatory cytokine cascade, drops their fever, decreases their shock, but some of the other biomarkers that we've used in the past, like procalcitonin, to decide if a patient has a bacterial infection, seem to be also elevated in a purely viral infection from the COVID-19 virus. We've also seen that this does seem to attack either directly the cells or the bone marrows, and lymphocyte levels are decreased, neutrophil levels and eosinophil levels. And there's some recommendations that we have not included in this, but of considering in areas of limited resources, considering these as poor prognostic factors. So advanced age, lack of eosinophils, lack of lymphocyte levels seem to carry a really high mortality level. The Wuhan experience in one case series that 81% of their patients that presented to the intensive care unit required vasopressors. The Seattle experience, that was the high demographic of patients from the nursing home, 71% of their patients presenting to the ICU required vasopressors. The Surviving Sepsis campaign is a ongoing campaign that looks at how do we resuscitate patients, how do we treat patients in shock in the intensive care unit. Came out with a consensus statement, and frankly, I think they came out with this way too early. And there's been this rush to publish stuff, and this was an extremely rushed publication. And we'll just go through it. It is very clear that it does say this was based on zero evidence, very anecdotal. They tried to extrapolate from previous viral pandemics, from pneumonias, particularly the SARS-1, SARS-CoV-1, and the MERS outbreak. And what they did find that worked in these patient populations, they tried to apply basically, but fairly blindly in this publication. They're saying that it looks like in patients who have shock and potentially ARDS, that a restrictive fluid resuscitation with a balanced salt solution seemed to be beneficial. Norepinephrine should be your first line pressor. They do recommend steroids for refractory shock, and this has been a moving target. And they're recommending 200 milligrams over 24 hours. Our own institution, and I think Josh Doohan is involved in this, is looking actually not at hydrocortisone, but using dexamethasone at fairly high doses for 5 days. But that's more for inflammatory induced ARDS. And then considering adding dobutamine if cardiogenic shock is suspected. Again, no data, no reference to the case series that have been published. The traditional goals, and Mong talked about this, looking at dynamic assessments and looking at point of care echo. But important to understand, we're taking care of many patients. We're trying to cohort these patients close together, but we do have limited resources as far as PPE, and traditionally going in and out of the room multiple times to do echoes or to look at patients, see how they're responding directly to a therapy is really, really challenging in these patients. And dynamic assessments, especially pulse pressure variation, and some of our flow track, lid code, those minimally invasive monitors are not reliable in the protective vent settings that we think are so important in these patients with ARDS. Filling pressures are completely unreliable in ARDS, and we've had patients on our high PEEP arm, which includes some patients up as high as PEEPs of 22 to 24. These patients are also put in the prone position. So luckily, I haven't heard many people refer to central venous pressure as a guide for giving a patient fluid. And in general, in the intensive care unit, we don't think these are very helpful in general and don't really describe the patient's response to fluid. Lactate levels, we have been trending these. It's very hard to find any reference in our COVID patients because they do present with liver injury and they may have different problems with lactate clearance. We do follow urine output, obviously, as a response to treatment, but these patients seem to have a very high incidence of renal failure, and it may not be due to volume status, it might be due to the cytokine storm. And it does seem as patients' inflammatory markers get better, that their kidney injury does also improve. Acid-base status, it's important to look at it because many of these patients have significant respiratory acidosis, have deranged electrolytes, and last week we had quite a few patients who had presented in DKA with complex acid-base status. So important to really delve into your ABGs and figure out why they are acidemic. The patients in the first 48 to 72 hours seem to present to our intensive care unit and to the emergency room with hypoxemia, but also with this cytokine storm. And we've been trying to resuscitate these people and use supportive care in the first 48 to 72 hours. We're targeting mean arterial blood pressures greater than 65. Traditionally, we're starting with norepinephrine and adding low-dose vasopressin. And as Martin said, if we do have concerns for pulmonary hypertension, we are increasing our vasopressin over adding other agents and over going to extreme measures or high doses. But it's not uncommon to see patients on 0.2, 0.3 of norepinephrine mics per kilo per minute, 0.1, 0.2 of vasopressin in this early stage. What we have been doing, but this is very controversial, is adding steroids. We've had great input from our infectious disease colleagues who are involved in many of these clinical trials, and they tend to be recommending dexamethasone instead of hydrocortisone. We're using hydrocortisone for refractory shock, regardless of adrenal insufficiency. We found that that we're treating and reassessing. If the patient doesn't seem to be responding to our fluid bolus, to our fluid therapy and vasopressors, we are assessing the heart with point of care echo. We had a lot of concerns from our cardiologists and from our neurologists about coming into the unit and worrying about spreading the virus throughout the hospital, that they didn't have dedicated machines to take care of, just to look at COVID patients. We're doing a lot of point of care echo. And it does look like cardiogenic shock or heart failure is a high predictor of mortality. We have patients as young as in their 20s, early 20s in the intensive care unit, and then we've had patients in their late 80s. And it's really important to try and differentiate their medical comorbidities and what they came into the hospital with, and figure out, is this a result of stress on their heart, or is this direct attack to the virus? And I don't think we have a great understanding of that so far. Well, and this goes back to the data out of China, there doesn't seem to be a huge rate of pneumothoraces for some reason. These patients' lungs, their compliance in general seems to be much better than when we look back at some of our other viral pandemics, particularly the most recent one, the H1N1, that their lungs tended to stiffen up very, very quick. The compliance in our patients seems to be very good until it's not, until the end. And those are the patients we're seeing referred for ECMO. The clinical trial, or the clinical descriptions of case series that have come out, tend to use our high sensitivity troponins, which we do not use at the University of Colorado. So when you look at these case series, you'll see very, very high troponin levels, but that's not the same level, and it's important to differentiate. Are they talking about the high sensitivity troponins or the troponins that are normally used? And the biomarker in patients with stress on their heart can be upwards of 23, 24, where we would consider that a significant non-ST segment elevation MI. In the early cases in the autopsy results from SARS-CoV-1 from biopsies, they were able to find in about a third of their patients that died viral RNA in the myocytes. So clearly it looks like this virus does invade the myocytes. And this is one of the major reasons why CPR has not been offered as a treatment, and discussed that once you're dealing with fatal arrhythmias and once you're dealing with fatal heart failure, CPR doesn't seem to be something that's going to rewrite that course. And they've already also found, and we're trialing in patients with refractory shock, pro-BNP levels. Arrhythmias, Mong and Martin talked about this, so I won't go over this, except to mention that prior to adding additional medications, the hydroxychloroquine and azithromycin, it's important to look at your QTc, especially some of these medications that have questionable benefit. So a quick mention on our iatrogenic and nosocomial infections. What we have seen, and it's difficult to know when to start antibiotics on these patients, especially transitioning them. Most of these patients that we've seen have been coming from the community, and in general, we're using community-acquired pneumonia treatment until they've passed the 72-hour course in the hospital. And then we think that patients transition to a different bacterial risk factors, and then we start treating for MRSA, excuse me, and gram-negative pathogens. The patients seem to initially do better and then develop worsening shock. And 48 to 72 hours is kind of our cutoff for transitioning their antibiotic regimen. What we also have found, though, and this will be very interesting when this trial comes out, is a reactivation of the virus that can happen after 4 to 5 days of critical illness. And we've seen all of a sudden high onset fevers, high onset inflammatory markers. And it's been very interesting because some of these patients have received the sarilumab dose. They have kind of really responded, and the FDA has actually in the clinical trial has changed that now patients can receive up to 4 doses, kind of based on this anecdotal experience that their IL-6 levels, their inflammatory markers have all gone down, but then there's this reactivation based on this. And it doesn't, we have not seen a ton of bacterial infections. So in summary, a restrictive fluid balance, fluid resuscitation seems to be preferred over high volume resuscitation. Norepinephrine is our first line treatment. We're using steroids for refractory shock. And as the patient's critical illness goes on, we should consider broadening our differential diagnosis. Thanks.
So I think because of our time restraints now, I think we should probably take some questions now instead of trying to rush through. We have 3 more talkers, but we're already at 7:30. So any questions from the chat? And we'll put all the slides up on the Teams page. In addition, Martin and I have made a document called Critical Care Clinical Pearls that basically focus on a lot of the information that we had talked about in one document. We'll put that up on the Teams page as well, in addition to some outside sources. So there's a question for criteria for ICU admission. We have a document also that lists our criteria. A lot of it has to do with kind of oxygen requirement as far as how much nasal cannula oxygen we need. I don't know. I mean, vasopressor support, obviously, arrhythmias, things like that. So I don't think the criteria is any different from kind of our usual ICU criteria. There was another question about how common is co-infection with a pneumonia, a bacterial pneumonia. I would say I don't think we've seen it any more commonly than other kind of viral, H1N1, any other viral infections, pneumonias that we've seen. We get kind of a tracheal aspirate and not a true bronchoscopy BAL due to risk of aerosolization. So we don't do routine BALs. One thing we do see is that patients will have persistent fevers. So even if we're on kind of adequate therapy, they'll kind of fever through during the course of the disease. And a lot of our cultures at the time, anytime an ICU patient develops fever, we get blood cultures and respiratory cultures, and the majority of them have been negative, just because I think a lot of the fevers are coming from the COVID infection. Heated high flow. There was a question about heated high flow. That's still a kind of a moving target for us. I think the concern is with aerosolization, but several groups, several other places on the East Coast, in Europe, and in China have used heated high flow, and so that's something that we are still struggling with, but we usually have not been using heated high flows in these patients.
So just to interrupt, our respiratory therapist did change that basically this week, and they were allowing us to use heated high flow as well as non-invasive ventilation, and we've had some, interesting experiences with placing heated high flow as well as non-invasive ventilation on patients and proning them awake. And some of this came out of New York, but with pretty dramatic improvements in patients that we would normally intubate. Some patients seem to be able to hang on.
I think that's great to hear, because that has been kind of a roadblock in a lot of us getting these patients extubated. The other difficulty is that once these patients get intubated, the wheels kind of seem to come off immediately, and they're on 80% oxygen and getting prone and things like that pretty quickly. So intubation is not something that we should take lightly in these patients. Another problem with weaning off the ventilator seems to be not just the respiratory issues, but our lack of adequate sedatives. So we're unfortunately using a lot of midazolam and hydromorphone just because of shortages in propofol and dexmedetomidine. And because of that, it's been very difficult to wean these patients off sedation to be able to get off the ventilator.
There was a question about convalescent plasma, and currently the process is that we consent the patient, we discuss with our director of the blood bank, they get a FDA approval, and I think we're up to about 9 patients that have received it. The anecdotal course of it seems to be about 4 or 5 days after the plasma that we seem to see an effect. Right now it's being, the inclusion criteria are extremely vague, but they're saying people who are very sick with COVID, basically. So we're trying to use it more. And I don't know, anecdotally, it seems to be very promising.
I think we got through the majority of the questions here. As far as antibodies, I'm not sure what our capability is. If anyone else wants to chime in, feel free. But if we, and then Leslie also said there may be new data on neurologic issues related to COVID. And I think that's something that I think we've been hearing a little bit about, and we'll be waiting for more information to come about. So I think we're going to end here if everyone's okay with that. And feel free to email us, and we'll have all these slides up on the Teams page.